This is how I got to Michigan. Dr. Steve Shire in the Detroit area of J&B Medical asked me, through the help of Jeff and Dave, I call them the brothers, little brother and big brother, when I come and talk to you all about health information exchange starting back in 2000, as well as what we're doing now, working with public and private partners in terms of precision medicine. I just left yesterday the American Society of Clinical Oncology meeting in Chicago, and they had the inaugural journal, and I encourage you to go to the website, www.journalprecisionmedicine.com, all one word, www.journalprecisionmedicine.com, and you can join or download the first inaugural issue of the Journal of Precision Medicine. Now, I'm very time conscious, so let me grab my mobile phone over there, at least I have it here. It is now 9:27. I'm scheduled to stop at 10, and we will regardless, okay? But before I do that, I want to recognize all the veterans in the room this morning, or active duty, Guard and Reserve. Will you please stand? Let me thank my fellow colleagues, brothers and sisters. And I'm in control of these slides here. It's been 15 years since the Institute of Medicine said to the Department of Defense and Department of Veteran Affairs, you know, we mobilized greater than 500,000 in preparation for the Operation Desert Shield, Desert Storm. And we did things correctly, but we didn't document it correctly. We gave a lot of men and women without uniformed services all types of immunization. They got involved taking all types of preparatory medication, et cetera, in anticipation of this large Gulf War, which ended less than 100 days and only a very few casualties. But they gave us some recommendations. Since that time, this is the 15th anniversary of those recommendations. And over time, the Department of Defense and the Department of Veteran Affairs has implemented some of those recommendations. I'm going to walk through that. Then I'm going to talk about Defense Health Information System that exchange a lot of data between DoD and Department of Veteran Affairs, as well as the Social Security Administration, every day. Then I want to conclude a little bit talking about precision medicine. These are my disclosures. I must add one more. I do not speak on behalf of the Department of Veteran Affairs nor on behalf of the Department of Defense. I am retired and proud of it. These are our learning objectives. Been in military, use objectives all the time. I think one of the key components is that when we look forward to the future, our future lies in precision medicine. And what you're doing here with Michigan Connect is a model for the nation. If you can collect the data and use that data to analyze it in a very professional way and try to customize healthcare for your population in the state of Michigan. You always have to have an executive summary. Here's a bottom line up front. Department of Defense and Department of Veteran Affairs have done an excellent job in fulfilling the Institute of Medicine 2000 recommendation, with few exceptions. We have not completely connected to the commercial world, even though about 60% of our healthcare takes place outside of the Department of Veteran Affairs. And with the VA Choice Program, it's going to increase for the Department of Veteran Affairs. We must connect that, and I think the state of Michigan will be a great example. Now, I'm going to ask the question, is anybody here from the state of Michigan Department of Veteran Affairs? It's a little bright in here. Anybody raise their hand or stand up? I would encourage you in the future, include them, include your local National Guard and Reserves, because they're part of that Michigan Connect. So that's, to my good colleague, Nick, that's order number one, okay?
Yes, sir.
Okay. What I want to do, these are the strategic objectives that the Institute of Medicine, that's the Department of Defense and the Department of Veteran Affairs implement. We have fulfilled most of those. I'm only going to highlight a few. One is being that, number one, we must have some form of electronic healthcare record. Okay. Number two, we must document in a serum repository, collect serum on our men and women of the military from the time they enter to the time they leave. I will tell you right now, we have the world's largest SIM repository, over 56 million samples. Some of those are repetitive samples. And we collect about over 2 million every year. They have at least about 5 or 6 on me, deployment, HIV testing. They take aliquots of that serum and store them in a very large refrigerators in Rockville, Maryland, as part of anything you want to look at to prevent another Gulf War-like illness or Iraq, Afghanistan-like illness. So far, we're blessed not to see that from that standpoint. They also recommend we try to document environmentally where our men and women will sign in these environments, and do we do environmental samples, and do we try to connect some of the information to the electronic healthcare record. We know where you're assigned, we collect environmental samples, we've yet not connected to your electronic healthcare record. However, we could if need be. The last thing that we've not done completely on is what we've done with the Guard and Reserve. We have an electronic healthcare record when they activate it to come on active duty. We do an annual assessment on our men of our Guards and Reserve every year. However, we have not developed a complete electronic record until they are mobilized or activated, other than documenting their dental, the immunizations, whether or not you were optical inserts, and certain other tests. Now, this is an example of how we document it. This is called the Medical Situation Awareness in the Theater, better known as MSAT. I will use acronyms and I will tell you what they mean. MSAT is basically a means of taking all of our data, environmental data, medical data, our electronic healthcare record on the battlefield, where you're located, and putting it into a situation awareness. When I was the senior commander on the battlefield, we integrated all these systems. We implemented the electronic healthcare record on the battlefield, 2004, 2005, and then we developed a common operating picture so you can see all this in a secure as well as sometimes unsecure environment. This was the beginning of this system. Before the MSAT system, we had what's called a Joint Medical Workstation, better known as JMUS. Okay? JMUS was designed to say, okay, I have this many doctors, this many nurses, this is what I'm seeing from a disease standpoint, this is the equipment I have, this is my blood supplies, and these are the people I have in their location, and this is the health care we're providing. Outpatient, emergency type care, hospital care, all integrated into one system, a nice dashboard that you can see and you can command and control and let your senior commanders and other medical personnel know what's going on. Later on, I'm going to talk about how to connect into the Department of Veteran Affairs. Here's some of the functionality. From a geographical standpoint, we can pinpoint that medical unit, who they're supporting, where they're located. We also have Annex Q. Annex Q is used for planning. How do you plan for a disaster? How do you plan to deploy? How do you plan where you're going to be in an environment? How are you going to plan for if you get X number of casualties, et cetera? How are you going to get them out of there? How are you going to get them to a safe place? All along the entire healthcare route. That's one of the important things about it. Also, too, all these systems are ICD-10 ready. So when we flip the button, we're ICD-10. Do we operate on ICD-9? Of course we do. We're ready to go with ICD-10. From an international standpoint, we can connect with our coalition partners. We know what is available, what is happening in that community, any outbreaks in that environment, whether it be that province, that city, that location, that locale. This system allows you to do all that. And I'm sure with the state of Michigan, you have something very similar. You have situation awareness of outbreaks. What has happened in this county, this location? That is a model for not only for this nation, but also for others involved in these type of operations. In the midst of all this, every month or any day of the week, you can see what is going on by the numbers. We have what is called in the theater, what data goes from a combat support hospital, a medic taking care of an individual, a corpsman, a technician, and a handheld device, laptop computer. That is stored in the theater medical data store, which goes all back go back stateside, Department of Defense, Department of Veteran Affairs, and I'll show that here shortly. This is the first report we started. We got started back in January 2005 when I said we first implemented. Since then, we have millions and millions of records that transmit since that time. A lot of those transmit daily. Outpatient system, Theater Medical Information Program, inpatient system called TC2, Command and Control, Theater Command and Control. All this is used to document the healthcare provided to America's sons and daughters on the battlefield. This is the inpatient data. We were documenting inpatient data, however, we were not transmitting inpatient data other than on CDs and discs until around about 2007. Now that takes place every day. And by the way, this is seen at the highest level in our leadership. You don't hear about it on CNN. You don't hear about it on ABC, NBC, or Fox News, or Face the Nation, but this happens on a regular basis. I mentioned briefly the Joint Medical Surveillance System. Why did I mention this system? Because it's a system of systems, and we call the MSAT system. It's one of those systems embedded within that system there. Very similar functionalities. You can report disease and non-battle injury. I can tell you at any one time in any one unit how many injuries. You know, in that theater, you still participate in athletic events. Any twisted ankle, broken bones, outbreak of the flu, sore throats, whatever it might be, we can break that down. Also, if there was a bad attack, how many had severe trauma, amputations, gunshot wounds, etc. That is broken down in this system, and you can see it geographically as well. We have all kinds of alerts. If we're concerned about an outbreak of, say, leishmaniasis, we can set the system and say, look, any leishmaniasis case will be reported as an alert. Not only does it get alerted on the battlefield, but it goes all the way back to the state of Washington. Let me tell you a story here. When we were there in 2005, we were administering the anthrax shots. And like always things would be, there's the anthrax shot, right below is the anthrax disease. One of our very hardworking, energetic medics was pushing anthrax disease instead of documenting pushing anthrax immunizations or shots. Within about an hour, I got an alert because Washington called me and said, what is going on? You have an outbreak of anthrax disease. So immediately we was able to locate, pinpoint that location by name and rank. And he got all kinds of love and calls, not because he was trying to do something wrong, at the fact that he had called something at the highest level in our nation back in D.C. that we had an outbreak of anthrax. We immediately corrected that situation, and he was recognized for being a great American. Not a very loving way. Okay. This is an example. You can do customized reports. You can categorize it. You can alert it. And also, too, a lot of time in this environment, we take care of U.S. contractors, U.S. civilians, and foreign nationals. We had about over 70,000 foreign national U.S. citizens helping us in this conflict, and still today at a lower number. You have to document their care, too. Geographically, case in point, here's a unit located here. Here are the conditions they're seeing, and we can see that geographically. You can zoom down exactly that location with all types of capability. And again, I'm not sure or not the state of Michigan has something very similar, but it's very nice to know what's going on up peninsula, mid part, as well as the southern part of the state of Michigan from a geospatial, geographic standpoint. That capability exists, it's all satellite-based, et cetera, et cetera. You can do something similar if you're not already. Now, what does all this mean? From the time you're injured on the battlefield, there's a handheld device that the medics, corpsmen may be carrying. That information is transmitted. You're picked up by an aeromedical evacuation helicopter. You're picked up, and information is transmitted with you. You go to a forward surgical team or a combat support hospital. Their documented information is downloaded. So before you get a chance to get on the plane to go to Landstuhl Regional Medical Center in Germany, information is being transmitted. And that information is being transmitted not only through the Theater Medical Data Store, but also through JMUs and other systems we have on the battlefield. Case in point, we've had some of our most severely injured individuals go from the battlefield of Afghanistan or Iraq, we were in Iraq, to Landstuhl Regional Medical Center in Germany, Walter Reed, Brooklyn Medical Center, San Diego Medical Center, all within 72 to 48 hours. Data is flowing. If they're so severe, they're going to go to one of our polytrauma centers in the Department of Veteran Affairs. That data is seen all en route. We provide en-route care, and later on I'll talk about the bidirectional health information exchange that takes place between DoD and VA. Here's a case point. We've had over 20,000 had some form of severe injury since we started in Iraq, Afghanistan. And if you make it to a combat support hospital, a level 3 hospital, your survival rate is greater than 90%. When we were there in 2004, 2005, had an individual get over 200 units of some form of blood products. We saved America's son. Okay? Here's some idea what you might see. Combat support hospital, very robust. We use all the same techniques we use in our fixed facilities back in the United States. We're very conscious about infection control, sterilization, et cetera, cool environment, safe environment, and a most important, secure environment. And we cannot do our mission without the Guard Reserves, because at this point, about 65% of our medical force come from the Guard Reserve. We had a number of units come from the state of Michigan to support us, not only then, but still to this day. Yeah. Just some examples of what transpires. They get to Lundstu, as I stated earlier, and they're put on what we call the air transportable team. And by the way, this is the Medal of Honor winner. Carpenter was the youngest Medal of Honor winner in the history of the United States military or a nation. This is Carpenter here. He went from the battlefield, Lundstu, to Walter Reed. He underwent about 40 surgical procedures. And by the way, he can skydive. He can still do his pull-ups and skydive. We'll do push-ups later on, don't worry. At the break, we also get out on the floor, we do push-ups, don't worry. He was recognized by the President of the United States. He's now enrolled in the University of South Carolina, continues education. Again, as I stated, the youngest Medal of Honor winner in our history. This is a great quote from Florence Nightingale. I love this quote. I want you to look at it for a second. If they could be obtained, they would enable us to decide many other questions besides the one alluded to us. The key is that she was talking about giving us the data, the information we need, transmitting that in order to provide the best possible care, the right time, the right place, the right location at that right moment. This was a joint effort that happens every day, what happened to Carpenter, between the Department of Defense and the Department of Veteran Affairs. However, as Carpenter decided he wanted to get his care outside of the VA in the state of South Carolina, how can we get that information back to the Department of Defense and the Department of Veteran Affairs? That's the connect we need to fulfill when we look at the Institute of Medicine 2000 recommendation. This is a quote. In spite of the Affordable Care Act, I still believe in this. Because still today in this rich, well-respected, powerful nation, everybody's still not getting the care they need. I'm going to digress now to my second objective, the Defense Health and Management System, better known as DHMS mission. Very simple mission. They manage all our health information systems. They make sure we get the right contractors, the right system, a lot of off-the-shelf technology, and can it fit or integrate with our environment and our mission? They support a large number of providers, 140,000 healthcare staff, 9.7 million beneficiaries around the world, and most important, they make sure that our healthcare systems on the ships as well as the air are operating in that environment, and that data is flowing throughout the country and around the world. We're the only system in the world that operates globally, 7/24, around the world, around the globe. From the special operation guys, our 18 Delta special medics, document they're doing in the special operation, the SEALs or Rangers, whoever it might be, all the way back to our healthcare system. So you can see from a handheld device, laptop computers, the clinical data store in the theater, all the way back to what we call between medical centers, DoD and VA. And right now, a provider in the Department of Defense and Department of Veteran Affairs can look into both systems to the BHIE. I see no reason why not that the state of Michigan and Department of Veteran Affairs cannot connect to the BHIE. You need a Social Security, you need to know only, you're seeing that patient, it validates it, you go into the Bidirectional Health Information Exchange. At that point, I'll call the TRI directional health information exchange when we connect with states like the state of Michigan. This is an example of the user data that's shared between DoD and VA. Look at that, 5.9 million records are going back and forth between DoD and VA. Administrative data, allergies, pharmaceutical data, lab, x-ray, pharmacy, you name it. We just need to connect the state of Michigan and the rest of 49 states and 4 territories. You can see the data speaks for itself. This is what we transmit. And as I said earlier, 60% of our care is in the private sector. Yet though, we don't get a chance to see that data back. We'll get a consult referral, those type things. But why can't we transmit that electronically? Why can't we do it here in other states? That's just summation of what transmit daily. You've probably never seen this before. This happened daily. How many elements? Why can't we just connect to the states? That's it about DoD, VA, the Institute of Medicine, what transpired since 2000 to 2015. I want to digress for a moment to talk about precision medicine. Precision medicine is very simple. Right patient, get the right drug or procedure at the right time, or medication the right dose. Precision medicine talks about taking 9 different elements. We're looking at your genetics, we're looking at your proteins, your amino acids, we're looking at other biochemical things, looking at your lipids, looking at all those things coming together to individualize or customize your profile. How do you respond to a medication? Are there any particular markers we can develop to see in you or a group of patients with different disease, whether it be diabetes, cancer, heart disease, whether it be autism, whether it be Parkinsonism, looking at what's unique about that group of individuals and customizing care, pulling the data from your EMR as well. That's what precision medicine is all about. Even though genetically we're similar, how we respond to different things can be different. Of all these 9 things that what we call predicted the future of precision medicine, I think a few that comes out. We're looking at developing 3D cells, liver being one, so we can test drug development, test interaction to toxicity, test new chemotherapeutic agents without having to always use at the patient level. So let's customize it. When you look at hemoglobin A1C, that's an example. We're looking at cholesterol levels, those are other examples. We start looking at things like breast cancer marker, whether it be Oncotype DX, customizing, saying patients, based on your cancer biology and your proteomics, your lipidomics, your metabolomics, then we stratify you. You're at low risk, intermediate risk, or high risk, and you then decide with your provider or not you should get some form of chemotherapeutic agent. One that is very, very important, I heard you talk about earlier, is what I call functional medicine. How do we get into the watching out what patients are taking? Functional medicine meaning that I'm going outside of traditional medicine. I'm going to try some other type of non-traditional medicine, whether it be vitamins, other different types of plants, other different types of solution. How do we integrate that into what's happening to the body and what's happening in healthcare? And the overall wellness model. Have we taken a cohort of the state of Michigan saying, look, we're going to look at this 1,000 or 10,000 or 100, and we're going to check their electronic record data, we're going to check their chemistries, and we're going to check a wellness program. We're going to follow this cohort over time and see what's unique about them. We're going to collect blood samples, urine samples, fecal samples, and follow them longitudinally and see what's unique about them as a group. And by the way, if you want to know more about these 9 different elements, go to the Journal of Precision Medicine, as stated earlier, the inaugural journal, first one to come out, it'll go in a lot more details. I'm going to talk about, I work with a company called Berg Health. Berg Health has discovered a new drug called BPM 31510, all based on precision medicine, looking at the biology, the genetics, the proteomics, metabolomics, lipidomics of patients with unique and very hard to take care of cancer. They failed everything else, okay? And I'll walk you through this example. They're working at MD Anderson, Palo Alto Medical Center, working with Harvard, working with a whole host of premier institutions in the country to try to tackle some tough cancers. And we're taking basically this. We're taking serum sample, tissue samples, urine samples, and running through what I call an interrogative biology process. What do I mean by interrogative biology process? We don't guess what the hypothesis is. We let the data tells us what we ought to be looking at based on doing different tests on those different type of samples. Because a lot of time we go in guessing. This is the question we want to try to ask. Sometimes we let the data tell us what we're looking and tell us the question to ask. And here are some patients with some very refractory cancers. These are actually true patients. Okay? And we've taken all their proteomics, genetics, tissue samples, urine samples, whole host of things, and blood samples, and we developed unique phenotype for those patients that's unique for them, how they're going to respond to a drug, or they'll get toxicity, how they're going to respond to BPM 31510. Okay? And that's the uniqueness about all those patients there. Okay? And again, they're evaluated by interrogative biology. And you have enough data in the state of Michigan with your health exchange to let the data tell you what you ought to be looking at instead of you asking the data. And then we look at responders versus non-responders based on all this data, bring it together. And it creates these unique patterns. You have to see it. It was going to highlight in the video. You can look at the video later. I'll be glad to leave it with you if you need to. Okay? Now, this is a true patient. Okay? This patient had a refractory cancer, taking all that data, and this is a PET scan. And you're going from left to right, you're going to see over time the whiteness is decreasing over time. This patient tried everything, and it failed. This is the phase 1 part of the study. And again, this is their unique phenotypic pattern for this patient. All the genetics, all the biology, all the lipids, proteins about this unique patient. Yeah. Personalized phenomes. We all respond different. We say, why does this patient respond to this drug or this chemotherapeutic and the other did not? Had a lot to do with our genetics and what are markers and how we respond. And this is one of the cases. This is kind of hard to believe because we asked the radiologist to look at these scans 3 or 4 times. And this is a VIP who tried everything around the country, and he said, let me try this. You can see the results himself over time as things start normalizing from left to right. Again, another patient had a very large mass in the chest, and the case below is a bladder cancer of the pelvis. And you can see from front, this patient here got into a complete remission. But again, this is all based on data, uniqueness of what you have. So let me say this now. Let me look at my time here. It is 9:55. I would like to highlight, can I see my last video? Is it going to work? It's about before we go. I know Jeff and Dave can help you out over there. That's Elvis' little brother right there going there. Okay. And then I'll take some questions, or if not, I'll hang around. Okay. While they're working, no problem at all. We'll continue to march. Now, are there any questions for me? If it's not public knowledge, I won't answer it. Okay. Okay.
We should have folks with microphones.
Give them a mic. Ask me some questions here. Yes, ma'am. We have a young lady right here. Okay.
You talked about all the great things around the electronic connectivity in the VA and Department of Defense, and touched upon integrating that into the commercial environment. What do you see as obstacles? Do you see it more political, getting that integration to occur?
That's a great question. I get asked that question quite often, to be honest with you. It takes leadership. It's leadership and understanding that you're going to protect that personal information in the way it should be protected according to the HIPAA. And then you have to do pilots. So what I tell organizations, when you're dealing with large government agency, don't try to grab it all at one time. Say, you know what, here's one little small clinic or one little small hospital in the Department of Defense or Department of Veterans Affairs. We want to do a pilot. We're going to look at this subset of this pilot, and we're going to see can we exchange that data and share it in a very private way and make sure it's secure. But that's what it is. Now, sometimes you run into what I call a Heisman. And those will say, well, over my dead body, you know. Then you have to just go political on him. This is where you ask, and my good buddy Nick here, you ask Tim or the governor, can you write a letter to the director, visiting director, VA Integrated Service Network, or the secretary or the deputy secretary of the Department of Veterans Affairs said, we have X number of veterans in the state of Michigan, and they go from the VA to the private sector back and forward. We want to make sure that we're improving quality, access, decreasing costs, and outcomes. In order to do that, we must be able to share data because right now, X percentage of your veterans in this state are going through all the systems. That's what it takes. Sometimes to write a letter. Okay? Yes, sir.
Can you hear me? Okay. The question is, you've talked a lot about precision medicine. You've talked about the opportunities with the data sharing with the state of Michigan and with MyHIN. Can you be a little more specific or expand a little bit more about the opportunities in that realm that we could do here in Michigan?
Absolutely. And I think it's just sort of dovetail on what the other young lady just asked me. Let me tell you how important it is. In this country, we're at about encroaching on about $3 trillion in what we spend in healthcare. A good part of that is due to repetitiveness of what we do in this country. Or in some case, being a clinician is unnecessary procedures, or in some case, defensive medicine. So if you look at I spent about 13 years in Europe. If you look at Sweden, Norway, Germany, countries that, especially Norway and Sweden, who've had electronic systems, and they can tell you from the time that somebody is born what they did or did not get in terms of what's requirement for prevention. We need to do the same thing in this country. Because right now, I can go to an emergency room here locally, so my back is hurting. Okay, they work me up. I go to the nearest VA hospital around here, or clinic, community-based outpatient clinic. They'll work me up. Okay, then I go to the medical center. They'll really work me up. The only thing that'll probably be exchanged is what happened between those civilian institutions, not what they did at the VA. And what if they expose me to a procedure that required me to get some type of invasive procedure, whether it be some dye, and I have a minor reaction. It's not exchanged. So that's what I see the benefits of all of this. Can we truly say we're going to do nation, state, local population health in such a way that we control those factors we can control, the people, the process, preventing things, being more productive, efficient, and effective, and last but not least, price, decreasing the cost of rising health care. I hope I hit on what you're talking about. If not, fire away again. Okay, next person there. Now, I don't want to suck up anybody else's time at 10:01 now. Okay.
A number of years ago, I knew a reservist that had a smart card they carried around, and it had a lot of information right on that card.
Yes.
Is smart cards still a part of the systems? And if so or not, how is it used, evolved? Where do you see it fitting going ahead?
Excellent question. Years ago, we tried something in the Department of Defense. We had a little smart card dog tag. And it did not fulfill all the environmental things we needed to sort of be successful. But I will tell you, the smart card is the way to go. I'm sure some of you are now getting those new credit cards, had that little chip embedded in them. Well, our military ID has had those chips on them for years. We call them CAT cards. But the same information can be put on a small card too. They hold lots and lots of data. I didn't talk a lot about the Bluetooth. You probably saw it on the slide, but you're putting the burden on the veteran, on others, when you say, well, here's your little Bluetooth, download it on your phone, download it on your computer or your iPad. That is good, but that's not the next step we should achieve. But the smart card, those are very, very effective. If we just allow the system in such a way to use those systems and be transported around. Yeah.
Hi,
Any
I'm
other
Gavin
questions?
Foss, privacy officer from Metro Health.
Oh boy, he said privacy officer.
Well, I just wanted to make a comment. I talked to the privacy officer at the VA facility in Battle Creek, and we have a VA outpatient facility on our campus.
Yes.
And we actually exchange information through the HIE Great
Excellent.
Lakes Health Connect already. So that is taking place at this time with us, at least.
But you know what? It's the community-based outpatient clinic, right?
A state one?
No, the VA clinic you're talking about, right?
Right. It's outpatient.
Yeah, we're
Federal.
called CBOCs, community-based outpatient clinics. And I'm glad you're doing it, because if that's where that person has decided that, or however it was blessed, I'm going to do the right things for the population that I serve. And I'll take the hit later on, or I'll get local permission. If it serves as a good pilot, that's a story you should tell at the highest level, provided that person gets some form of what we call top coverage. Or they most likely did get permission. If not, I didn't hear it here. Okay. But it's the right thing to do. That's the point I want you to take away. Okay. It is now 10:04. I'm sure the next speaker is getting nervous by now. Let me say this to you. Thank you. I'll be around. God bless you, and God bless America. And I'm proud to be briefed in the state of Michigan. And I can say, what? Go Trojans. Oh. That was a joke. I got the right colors on today. I got your attention. Thank you all.